Thank you very much. And now to bring it all together, Sue Berry is here from the University of Minnesota.
Oh my, I'm already on yellow. Well, that's all right, because I should have changed the title for this. It should be What We Don't Know About Nutritional Management for Inborn Errors of Metabolism. And I think one of the things that you've perceived from our conversation here is that just as in your other favored diseases or complications, we are only beginning to touch the surface of what we know in these very specific and rare disorders. All right, disclosure slide. We usually don't talk about the disclosure slide, but I mentioned this because all of the things that I'm disclosing here I've gotten into the middle of because we don't have a very good path for care for children with rare inherited metabolic diseases. So I'm part of the Midwest Genetics Network. I'm part of the Newborn Screening Translational Research Network, the Urea Cycle Disorders Consortium, and the Society for Inherited Metabolic Diseases, the Secretary's Advisory Committee for Heritable Disorders in Newborns and Children. Not because I want to do all these things because it's, sort of fun or something. They are interesting and very valuable, but it's because we have some important questions that we have failed to address. And that's why I wanted to do that. But at the same time, I'm not speaking for those organizations. I'm not speaking as a representative for those. Like others, fortunately, finally, we're getting somewhere in terms of trying to do more interventions in rare metabolic diseases, so I'm happy to have been able to assist with that, primarily in the urea cycle disorders. And I'm not going to talk about off-label use of drugs for those who are worrying about this, not about CME, but these aren't drugs. We talked about this earlier, and maybe some of them should be, but we're not there yet. So I was tasked with something that I found incredibly overwhelming, which is to describe inherited metabolic diseases. And each of my cohorts has been able to describe an individual facet of this and tell you how overwhelming it is, and I get the whole thing. So I'm going to keep it simple because honestly, we're kind of at stone knives and bearskins in what we do with this. It's a large class of genetic disorders. They're typically single gene abnormalities that are primarily nuclear. I hedged this after I read Marnie's slides because, of course, some of them are maternally inherited because they're mitochondrial disorders. But most of them are autosomal recessive, but very few are X-linked. Essentially, what we're mostly dealing with is problems in catabolism, failures to degrade or to synthesize or degrade compounds, and it's mostly degradation. And mostly these are due to single enzymes in those pathways, sometimes associated with enzyme cofactors that Chuck described for MMA, for example. Now, many newborn screen disorders, we spend a lot of money in public health for assessment and detection of these disorders, and they're primarily detected not by genetic but by metabolic assays, by metabolite assays. So right at the beginning, we have, if you will, generalizations about the inherited metabolic diseases that oversimplify them. This is everything anyone needs to know about metabolic diseases, sort of. Obviously, what we're really dealing with is the consequences of these errors in metabolism. You can end up with a decreased product. In PKU, for example, in untreated PKU, you'll have patients that have very blonde hair because tyrosine is an immediate precursor to pigment, normal pigments. There's obviously more consequent errors that happen from that, but you get a decreased product. You may have increases in precursors, and we heard a little bit about that, again, in the context of PKU, and also even more objectively in the methylmalonic acidemia, where you get tremendous increases in precursors that can have toxic effects. You can shunt to alternative pathways, and sometimes this has metabolic effects we don't consider. You also can use that diagnostically. Sometimes it'll increase a downstream metabolite that you can use for testing. Example is orotic acid in urea cycle disorders. It's a shunt to an alternative pathway. Well, our treatments, I hesitate to tell our residents and students this because it makes them think that our jobs are so easy and they think we're wizards, and we're not. Because the treatments are either to replace the product or restrict the precursor. That's pretty much it. That's pretty much it. Sometimes you're fixing energy, and sometimes we don't have great tools to fix these things until we accomplish what Chuck talks about, which is gene therapies. There are broad categories of inherited metabolic diseases or inborn errors of metabolism where nutrition impacts care, and I sort of grouped these by metabolic paths. They're disorders of protein metabolism, and Chuck's disorder, methylmalonic acidemia, is in this group of protein metabolism, although there's a little branch with branched chain amino acids, with branched chain, odd chain fatty acids. Disorders of carbohydrate metabolism, you have sort of groups of carbohydrate intolerance. Galactosemia would be the example of that, for example, or hereditary fructose intolerance. You have disorders of failure to generate glucose, like glycogen storage diseases or gluconeogenesis and glycogenolysis problems. Fatty acid oxidation disorders are a whole group of energetic disorders that primarily have to do with failure to generate ketones. And then the mitochondrial disorders, where many of the manifestations or some of the things we're seeing in terms of energetic needs or mitochondrial poison overlap what happens in the classic mitochondrial disorders. Marnie described the primary mitochondrial disorders, but many of the disorders that we take care of in protein or in fatty acid oxidation would be, I would say, essentially secondary mitochondrial disorders. So there's a broad scope of pathways that are intersected by these disorders. Chronic treatment. This is pretty much what we got. You either restrict or supplement. And that's pretty much where we are. Is that fair? I mean, it's hard to say, but that's pretty much what we have to do. You make sure you have adequate caloric intake. So we talk about giving lots of glucose. Martin talked about giving glucose in the mitochondrial disorders. And anybody who takes care of inherited metabolic diseases has a standard format, 1.5 times maintenance of D5, half normal saline. That's your treatment. There you go. That's it. Sometimes some intralipids, sometimes not, but basically lots of glucose. One of the things that's really a problem is that I think we are not very good at thinking about adequacy. I think we overdo some restrictions and underdo others. Chuck's described that very cogently in his assessment of what we think about for MMA. I would extrapolate what he says in that particular disorder, for which he's had the fortune to be able to look at it analytically, to almost all the other disorders. We used the same strategy for every one of them, which is, if it's bad, take it out. And maybe that's not what we should be doing, or we are not taking it out the right ways. So you have to monitor adequacy. You have to make sure you have enough protein and not too much in the protein disorders. If you restrict fats in fatty acid oxidation disorders, you can make people really sick. You have to have enough essential fatty acids. So we can overdo in our zeal to improve. Cofactor supplementation is really important in some cases, in some disorders. When you have a vitamin responsive disorder, about enzyme, about half the time the error in that enzyme responds to a cofactor. Pyridoxine responsive homocystinuria, the methylmalonic acidemias where they respond to B12, Kuvan for PKU. And then we got scavenger therapies, ways to get rid of stuff. That's primarily been used most effectively, I would say, in urea cycle disorders, where they use agents that provide alternative nitrogen loss. If you want to think of carnitine this way, though, and I think some people do, carnitine is, in its essence, a scavenger therapy. It gathers stuff up and gets rid of it, as well as providing appropriate bioenergetics. Also something we don't know very much about. And then monitoring of toxic metabolites. You have to keep track of whether you're having the desired effect. An example in PKU is that you get your levels down. You match Phe, and you use that. So what are the biomarkers? Most of the time, they're really toxic things that we try and bring into what we call normal ranges, but they aren't normal at all. They're not normal ranges. We bring them down into less toxic ranges. And of course, Chuck alluded to this, but in many of the disorders, you have acute events whether you want to or not, no matter how careful you are, no matter how good a doctor you are. There are acute events that intervene with all sorts of metabolic events that take place because of the acute event. I'm not going to talk a lot more about it in this, but one of the themes that recurred in some of this that I should have emphasized more was the role of the inflammatory response as a secondary phenomenon from the injuries that take place, and sort of the feedback loop that you're going to develop in a situation where you have a metabolic decompensation that induces tissue damage, that brings an inflammatory response, that brings it back, and it hypes up everything that goes wrong for a person with a metabolic disease. All right. We ended up choosing some paradigm conditions to help you think a little bit about this. I'm grateful that the organizers chose this profile, because you could have picked a lot of different things, but these are ones that really we actually have a tiny bit of evidence about, for which I'm grateful. Denise very carefully and appropriately described the neurotoxic accumulation of phenylalanine as the key management strategy, using blood phenylalanine as a surrogate for what must be happening in the brain. We don't know very much about that. There are treatments that actually work on that. For example, we didn't talk about valine isoleucine leucine, our branch, using those as ways to interfere with transport of amino acid phenylalanine into the brain. And that's another strategy that hasn't really been talked about, is how can you make brain-specific therapies. That brings the issue of insufficiency right to the fore. When they first started treating PKU, they killed children because they restricted all of phenylalanine, and by golly, you need essential amino acids. There it is. And so tyrosine becomes a relative essential amino acid in that setting because you've restricted phenylalanine. It proves the cofactor effectiveness. Here, tetrahydrobiopterin is effective in selected cases, and it really has a tremendous impact on PKU care. The spectrum of the phenotype is so important in thinking about PKU as a paradigm disease. It's mirrored in every other disorder, which is you might or might not have a cofactor response. And if you are, then your treatment's much simpler. You might have a more severe enzyme deficiency, which varies your amount of phenylalanine tolerance. And so the most severely affected persons with PKU are going to have really limited tolerance of protein, whereas the patients who have slightly milder mutations can have a lot more generous. When you're thinking about gene therapy, you can see that you would need a lot of gene therapy to make a big improvement in a classical PKU. It also highlights the concerns about conditionally essential nutrients, especially in catabolic states. I would also say that it highlighted, as we improved PKU treatments, our understanding of micronutrients that we didn't really pay as much attention to, but you can make kids selenium deficient and zinc deficient and all sorts of other nasty things deficient if you give them funny diets. And that's what we did in PKU when we were first starting to do it. Marnie ended up talking about nutritional needs in mitochondrial-associated disorders. These are a really heterogeneous group, and both primary and secondary mitochondrial impacts are important in thinking about this diet. For mitochondrial-associated disorders, there's really no defined optimal diet, and she pointed out, and few trials have examined this issue. Few trials have examined any of these issues, so it's pretty easy to say that. The primary intervention for mitochondrial diseases right now, there are some really important and useful things, but really the efficacies of these have been very poorly demonstrated. And I think others and Marnie have mentioned that these are really being handled and thought of in the interventions more as treatments than as supplements. And we have that ambiguity that I think this group will end up needing to address as we think about how we assess special needs nutrients. When are they drugs? When are they not? What do we do if we make them drugs in terms of access and availability? She mentioned, I think this is correct, is to maximize appropriate diet components, energy, micronutrients, avoiding fasting and dehydration, and of course in mitochondrial disorders, antioxidants are clearly emerging as an important element. A limited number of disorders have a specific or diet cofactor need, and in those cases, supplying those are super important. Chuck gave us a really outstanding example of what you can do if you invest in studying a disorder at length and in more detail. He demonstrated extremely nicely, I think, with these studies, he and his colleagues, about the importance of using the medical food. And the way the medical foods were made is they're pretty much all made the same way. You just swap out the amino acid you don't like, whatever it is. They otherwise look pretty much alike. And in fact, that probably leads to amino acid imbalances in, I'm going to guess, all the disorders. We're just not very good at figuring that out because we don't have the cohorts to do it, and we don't have the money to do it. But it results in excesses of some amino acids and what appear to be deficiencies, which aren't real deficiencies, in others. And we have lots to learn from studies like the one Chuck explained about how we can optimize or improve the products that we provide to patients so that they don't cause these iatrogenic deficiencies. Chuck and his studies didn't emphasize this in his slides, but this can really have such profound effects that it causes growth limitation. That's not a good thing. I'm going to guess that poor growth and obesity is totally related to our failure to understand the broad spectrum of nutritional needs in these children. So he mentioned the specific complications in this cohort of patients about leucine excess. And leucine and branched-chain amino acids have their fingers everywhere, everywhere. So when we think about the comparison of inherited metabolic diseases, because we're using this as sort of a paradigm, there are some nutrient limitations that emerge based on the disorder. For example, tyrosine and PKU. Patients who are treated with scavengers and urea cycle disorders end up having branched-chain amino acid deficiencies. MCT, if you don't give a patient with long-chain fatty acid oxidation disorder MCT oil, medium-chain triglycerides going under the block, they get into trouble. That's really life-preserving in those individuals and really helps them manage their disorder. So many of the nutritional requirements are likely the same, although we don't know that. They're likely the same. But in inherited metabolic diseases, our job is to run them very close to that edge of what the bare minimum is required. We're obviously not striking that balance optimally, as both Denise and Chuck demonstrated. We have lots to learn about how to strike that balance so we get enough and not too much. We have the risk of limitations of micronutrients in artificial diets. We didn't talk about this specifically, but it's been well demonstrated, again, mostly in PKU, that extrapolates to others. One of the things that Denise didn't emphasize, but I think is really important observation, is that depending on how you deliver the amino acid or protein equivalent or the nitrogen equivalent, it may or may not be as efficient. So TPN is not as good a way to give protein to patients as giving whole protein is, bottom line. Why that is, it's not exactly clear to me, but it's clearly different. There's differential effects in the catabolic state. I'm going to guess that there's different utilization of protein components in a catabolic state that further exacerbates these imbalances. We also know that every time we monkey with giving altered diets, you alter the microbiome. We talk about giving antibiotics to patients to reduce propiogenic bacteria. That means if you're doing it, given flagella, every once in a while you're just wiping out the microbiome. Thank you, have a nice day. Yet people do it, and it's probably important. I will also point out that costs and access really limit our ability and patients' compliance. We don't have stable ways for patients to receive needed medical foods. So what are our challenges? Everything talks to everything else. Every pathway talks to every other pathway. So when you monkey with one, you're monkeying with one downstream. And we don't take that into account generally. We think we're simple. We take out the phenylalanine and we're done. And it's not that simple. This changing intake undoubtedly impacts the gut microbiome. We haven't studied that in any major degree. Different consortia are beginning to tackle that. Urea cycle disease consortium has a full project on thinking about gut microbiome and its impact in urea cycle disorders. We've just heard, and we've known for a while, but we hear even more cogently, that the medical foods, we did the best we could in making them, but they're probably not optimally constituted, and they probably need to be constituted by disorder, would be my guess, although some of the things Chuck's finding are probably generalizable. And the broad spectrum of genotypes in the various disorders means that we need varying interventions, really complicating things. We talked at that beginning intro section about the nutritional needs changing through the lifespan. Well, if treatment is needed lifelong, how do you learn about those changing nutritional requirements? What are you going to do with a well-treated patient who's been PKU treatment compliant all their life and now they're 60, now they're 70, now they're 90? What do we do? And how do we change that? And do we do a better job? So we had questions that we were asked to address, and I've got, unfortunately, overly simplified answers because we have more questions than answers, I would say. So are the disease states responsive to this nutritional intervention? I would say yes, despite the caveats I've placed for you. We've done a really remarkable job in improving outcomes, which is, if you want to think of the simplest outcome, survival and useful life. We've done quite a bit in that direction. We have a long way to go. What are the additional complexities? I don't even know where to start with this, but genotype variation and stage of life would be two examples that are really critical in inherited metabolic diseases. Does a dose-response relationship exist? Yes, I would say in almost all metabolic diseases, because there needs to be a clear balance between enough and not too much. And we're only marginally good at accomplishing that. And what are next? I'm going to talk over just for a couple minutes just because I have to throw this in. What are the gaps in information? I don't even know where to, I think I've outlined some of them, so I'm not going to go further into that. Don't get me started on it, as I said to myself there. My 2 cents is that we have a very limited evidence base. There's almost no longitudinal follow-up natural history studies in inherited metabolic disease. CHEX represents one of the very few. PKU is the longest studied disorder with the most natural history. Beyond that, it doesn't exist virtually at all. And so I ask about evidence base, and people said grade, and I go, ha, ha, ha. Yeah, it's not going to happen. It's not happening. There's little longitudinal follow-up. There's almost no clinical trials. It's observation and limited documentation. So if you tried to do the evidence base today, you just would get nowhere. Medical foods and supplements are in an unusual regulatory position. I'll just put it that way. I just spent the last 2 years working with the Secretary's Advisory Committee, writing a paper about medical foods and why they need to be covered by insurance. So we don't have good coverage for the optimal therapies that we have, even though they're not that great. And that's a tremendous impact and burden on families. And by the way, when you're age 21, you no longer need special treatment, right? Wrong, but that's where it is. And so I'm going to call out GMDI, the Genetic Metabolic Dietitians International, for their rigor in trying to develop consensus basis for therapies so that we have a substrate, a baseline to work from. I think that's the only way we're going to get where we need to in terms of studies, but I can't speak emphatically enough about the need for research funding to improve these outcomes, because I think, as you all do, that some of these observations are very generalizable to other rare disorders and micronutrient needs. So with that, I'll stop.